Good morning, everyone. This is Leanne Griffin with the Florida Alcohol and Drug Abuse Association. We do expect to get started on time in about 5 minutes. I have also added some information, some technical information in the chat panel that you might find helpful. So thanks very much, and sit tight. Good morning, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Removing the Stigma, Changing the Public Outlook on Substance Use and Recovery. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, I'm the host, by using the Q&A panel. Please use the Q&A panel to send any questions as you think of them throughout the presentation, and the presenter will address them as time permits. Our audio is broadcast through the internet to your computer. However, if you experience poor computer audio, there are a few options to try on screen right now. These options are also posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio portion of the presentation and view it on screen to receive a statement of credit. The recording of materials used in today's presentation will be available on the FATA website within 5 business days. Also, a PDF version of this PowerPoint presentation will be emailed to participants also within that same time frame. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation on the FATA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FATA as part of registering remains confidential. Statements of credit will be posted within 5 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive continuing education credits or to access your statement of credit. Do note that the evaluation will close at midnight on Thursday, October 11th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, please be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you're certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Do note that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a statement of credit if you do not attend the entire webinar, and we're not permitted to provide partial credit. Hannah Rhodes is the Director of Training and Technical Assistance for Faces and Voices of Recovery, and recently developed the National Recovery Institute with her team. Ms. Rhodes has been working with individuals with substance use disorder, trauma, and mental health conditions both formally and informally for 32 years. Her passion for social justice and equal voice has been the source of her motivation and inspiration throughout her career. Her commitment is to inspire, promote, and advocate for system change at the state and federal level to create a higher standard of quality in both service and approach to better assist those in vulnerable populations. We're very pleased to have Hannah Rose join us today. Hannah, if you're ready, good morning, and I'm going to go ahead and turn control of the presentation over to you. And I'll go ahead and bring up your slides.
Thank you, Leanne, and welcome everyone. I am so pleased to see there's 100 of you on this presentation. And I also want to thank FATA and the Department of Children and Families for making this opportunity available. I'm honored to be your presenter today, and your participation in this presentation tells me that you're all interested in ways to be change agents and help diminish stigma around substance use disorder, and for that I am grateful. So my hope today and goal today is to help you understand the science behind substance use disorder and recovery. I'm also doing a section on how to dissect the current stigma-enhanced language and give you some tools and tips and resources on how to change the language when we talk about substance use disorder. And then finally, learning some individual strategies to change the public outlook on substance use disorder and recovery. I'm also going to take a risk and be a little bit vulnerable today, as I'm a person in long-term recovery, and what that means is I was a methamphetamine addict, IV drug user, and I have not used substances for the last 34 years. So I'm going to weave a bit of my story in to help you understand the damage of stigma and how you all can make this better for people that are struggling with this disorder. So what is stigma? It's defined as a set of negative beliefs that a group or society holds about a topic or a group of people. It's a major cause of discrimination and exclusion and contributes to the abuse of human rights. When a person experiences stigma, they are seen as less than because of their real or perceived health status. So I wanted to ask the group a question. What are some other populations that you feel are still being stigmatized? And you could put some answers in the chat.
And Hannah, ask your question one more time.
I wanted to ask the group today, what other populations do you feel are still being stigmatized in 2018?
Thank you.
While you're thinking about answers on that, stigma is a public health issue. It contributes to high rates of death, mass incarceration, and mental health concerns among dependent populations. Stigma is rarely based on facts. There's a lot of assumptions, preconceptions, and generalizations around vulnerable populations, which results in prejudice, avoidance, rejection, and discrimination against people who have a socially undesirable trait or engage in culturally marginalized behaviors such as drug use. And it happens at 3 levels of society: structural, laws, regulations, and policies; the general public, attitudes, beliefs, and behaviors of individuals and groups; and probably number 3 is the most dangerous of them all, is the internalized negative stereotypes. Self-stigma leads to deep shame, and this shame can keep people from seeking help. So Leanne, I would like to do the first poll and ask the group to participate in our first question.
All right, that's fine. Let me get that. I'm going to go ahead and open the poll. And the question that you should be seeing is, do you think that general public now understands that substance use disorder is a medical condition? And you should see that question in your poll right now. And people are beginning to answer that.
Thank you, Leanne.
And we'll give it a few more seconds. All right, we'll give an opportunity for a few more people to respond. We're close to 60% response rate. Okay, I'm going to go ahead and close the poll. And it'll be a few seconds for that to close. Great. I'm going to go ahead and share the poll results. And Hannah, do you see the poll results?
I do. Thank you very much.
Good.
And thank you to all who participated in the poll. So a large percent still believe that the general public does not understand that. And so my next question, and if you wouldn't mind putting your thoughts in the chat box, is why do you think the public attitude is so difficult to change? And Leanne, I have a technical question. I am not able to see my chat box now.
Oh, okay. What you can do, and you'll be able to see it, Hannah, is take your mouse and move down to the bottom center pane, and you'll see some icons open up, and you want to make sure that you click on the little speech bubble. You'll see several icons across the bottom of your screen after you kind of scroll over that space.
Thank you very much. There it is. And so someone mentioned that because people have grown up with these attitudes, so absolutely that is one of the reasons the public attitude is difficult to change, is people have been brought up with different belief systems. I mean, there was a time in our lives that we believed that the world was flat. And then I can tell that I'm talking to people that know a lot about this, and someone else mentioned that people don't understand how the brain is changed due to substance use disorder, and they don't understand how it could be a medical condition. So we're going to go into a little bit of, thank you for your comments, and please keep adding them. I'm very interested to hear about your thoughts, because I always can learn from you when I'm doing presentations. So here's just a brief past attitude history. This is from the History of Drug Abuse, written in 2016. So in the 18th and 19th century, people believed it was around the moral model, which meant that it was purely willpower or moral strength. And so if somebody wasn't able to stop using substances, they were weak-willed or a moral degenerate. And then in the late 19th century into the early 1930s, the belief was that alcohol and drugs are in and of themselves dangerous substances, and anybody using them will become addicted, which we know is not true. And then the 1950s came the addictive personality model. So you have to have an addictive personality, and therefore, if you use substances, you would automatically become addicted. Then became I don't know how old all of you are, but I remember the ads around "This is your brain on drugs." And it was a scare tactic, of course, with the best intentions, hoping people wouldn't use substances. But what it does say is that your brain can never heal. And we also know now with the science that we have that when people do move into recovery, that their brain can heal. So in the 1990s, there was incredible strides on research of the brain, and it's referred to as the decade of the brain. Technology had gotten to a point where many scientists believed that they would be able to unlock and uncover all secrets of the brain, information they'd never had access to before. But what they did learn is the brain is more complicated and intricate to understand. And the biggest thing they learned from their new research is how much they had to learn. One scientist described it as this: if you want to think about the brain like a computer, which is not a fair comparison because the brain is more like the internet. So we know so much more now, and we're going to continue to learn. So in 2004, Faces and Voices of Recovery commissioned Peter D. Hart Research Associates to survey public attitudes about addiction and discrimination. The findings included the following: 43% of Americans say they would be less likely to vote for a candidate for governor of their state who's in long-term recovery. 27% of employers admit they would be less likely to hire an otherwise qualified job applicant because they learned the candidate was in long-term recovery. And the recovery community responded like this: 19% of people in long-term recovery fear being fired or discriminated against if their history of substance use disorder becomes known. 24% had been personally denied a job promotion. 12% had been denied health care coverage or had to pay a higher premium. So that's an excellent example of discrimination. 39% have experienced shame or embarrassment by being in long-term recovery, and 63% of people in long-term recovery indicate the importance of conveying to the public how shame and discrimination hinder the recovery process. So have these attitudes changed? So that study was done in 2004. So just 4 years ago, in 2014, Johns Hopkins Bloomberg School of Public Health Research did another study. And these are the points that they came up with. Stigma affects all of us, and nearly everyone has felt stigmatized or has stigmatized others at some point in their lives. The general public was more likely to have negative attitudes toward those dealing with drug addiction than those who were dealing with mental illness. And additionally, researchers found that people don't generally support insurance, housing, and employment policies that benefit people who are dependent on drugs. So perceived stigma can cause major harm to people in their social lives. The chronic stress of discrimination may affect the mental and social health of individuals who use substances. People who use substances can feel pushed to the outskirts of society and may lose touch with their community, family, and experience profound loneliness and isolation. In fact, isolation is one of the key factors from all the people that I have worked with throughout my time in this field, and also for myself. Isolation is very, very dangerous, and substance use disorder definitely leads to isolation. So the results of this study, remember this was just 4 years ago, 64% said companies should be able to deny employment to people with substance use disorder. Only 25% of the respondents said people with mental illness should be denied employment. So that's an example of substance use disorder being highly stigmatized. 43% of the respondents said people with substance use disorder should be denied health insurance benefits, and only 21% of respondents said people with a mental illness should be denied health insurance benefits. And again, more results. Only 22% of the respondents said they would be willing to work closely on a job with a person with substance use disorder. 62% said they would be willing to work closely with someone who had a mental illness. And an estimated 3 in 10 respondents said recovery from either substance use disorder or mental illness is impossible. So I'd like to ask that question here. What are your thoughts? Do you believe that people can recover from either substance use disorder or a mental illness? So I just want to put that question out there and just give you a moment, and if you'd be willing to put some thoughts in the chat box. So again, the question is, do you believe that substance use disorder or mental illness is impossible? So recovery from either. Thank you, Albert. They can recover and heal. Some other thoughts that people can recover from substance use disorder if they remain abstinent from all substances, but you don't believe everyone can recover from mental illness because it depends on the illness. I'll give you another minute for some more thoughts. Very positive thoughts coming. Yes, I've seen people with both mental illness and substance use disorder recover. I want to thank you for sharing that you have some family members that have recovered from alcohol use and they stayed that way until they died, so they had long-term recovery. So very positive responses. So I have one more question for you before we move into the next piece. What do you believe the general public attitude to be in 2018? And thank you for your comment. I'm surprised to see that stigma is still so high, and I agree with you. I think we've come a long way. I think there's a lot more supports in place, and I think people are moving in a direction of looking at this disorder in a different way, but we have a long way to go. And that's what you're all for, is to be change agents around that. So stigma and discrimination can be used interchangeably here. So there are specific consequences of disclosure of substance use disorder. So people are afraid to talk about this or seek help because they're afraid of these following things. Obviously, engagement with the criminal justice system through arrests, prosecution, incarceration, being denied access to medication-assisted treatment in the criminal justice system. People are dying because they're being denied certain medication that they may have been on before they were incarcerated, but we don't hear that much in the news. There are many people afraid of temporary or permanent removal of their children, loss of employment, and denial of housing. So let's take this and break this down, and I really would love any input that you'd like to put in the chat. So let's compare. There's non-stigmatized conditions and stigmatized conditions. And so what that means is, for non-stigmatized conditions, for example, cancer, there's low perceived fault where people don't believe that, of course, that's anybody's fault, and also low perceived control. In other words, somebody doesn't have any control over if they get sick. But stigmatized conditions is completely opposite, particularly substance use disorder, where people still feel that it's the individual's fault and that they should be able to control this disorder. So SAMHSA, Substance Abuse and Mental Health Services Administration, recently disclosed that substance use disorder is among the most stigmatized conditions in the United States and around the world. And some healthcare providers treat patients with substance use disorders differently. And I'd love to hear some examples of that. If what have you seen in the work that you're doing? And I'm not sure what you're doing for work or how involved you are in this, but why do you think some healthcare providers may treat a patient with substance use disorder differently? I'll give you a minute to respond to that. So what are some thoughts on why some healthcare providers may treat a patient with substance use disorder differently? And thank you for your comment. They only see this disorder as a behavior issue. They may get frustrated if they are caring for a patient and then the patient gets cared for and leaves and continues to come back with different conditions due to this disorder. Oh, very interesting comment that they may think they aren't being truthful when reporting their use or symptoms. What are some other thoughts that you have? They may have some old hang-ups. I really appreciate people sharing some of their personal story. So my daughter, who is recovering from drugs would tell me she was treated differently and didn't want healthcare providers to know she had a substance use disorder. So again, I think we have come a very long way, but we have a long way to go. So as much as we can share the information around the science, the brain structure changes, which I'll talk about in a little bit, the language, which I'll talk about in a bit, we can start moving this where people are treated with dignity and respect. Another negative impact of stigma and discrimination, people with substance use disorder who expect or experience stigma have poor outcomes. So some examples of that be not, as somebody just mentioned, not wanting to tell a healthcare provider that they have a substance use disorder. They may not ask for help. They may not even have opportunities to get help. They don't have health insurance. They may have lost their housing or their community, their family, so they're isolated. There's many reasons why people may have poor outcomes. So we need to think about how can we change that. I'm sorry, I skipped a few slides there. So another negative impact is even when people do get treatment, discrimination can continue and contribute to poor outcomes. And there's still negative discrimination and stigma within the recovery community. So some examples of that are for people that are on medication-assisted treatment or medication-assisted recovery, even within some of the recovery community support groups, for example, a 12-step program, there are some people within those 12-step programs that don't believe medication-assisted recovery is a recovery path. And so folks who want that kind of help and support from their peers will often participate in a 12-step program, but not admit to the fact that they are on medication-assisted treatment because they feel pushed out even from their own peers. Someone mentioned from the slide before, lower self-esteem can affect the outcome too. Absolutely. I can share personally the amount of shame that comes with having a substance use disorder is profound. And obviously the consequences of substance use disorder can create this kind of shame. So to be able to get out of that downward spiral is a very difficult thing to do. And people need all the help and compassion that they can get in order to be able to overcome the hurdle of such a powerful disorder. And funding for substance use disorder treatment is challenging too. There's often some discrepancies on where funding goes. And for the organization I work for, we're always advocating for more funding to go into the communities so that when people leave treatment, whatever kind of treatment they have for the acute treatment first, that there's funding for community organizations and their partners to be able to continue to help people, particularly through those first years of recovery when they leave treatment and are now faced with things that happened or things they've lost or relationships that they need to repair. They need a lot of support. And so we're really advocating for more funding for all the communities and states to be able to offer that kind of support. And as mentioned earlier, people in recovery are often under suspicion even after being in recovery for years. And I was wondering what you thought about that. So why do you think they're still under suspicion? Say somebody has been in long-term recovery for 15 years. What are your feelings on why people are still suspicious? And I really appreciate the engagement today. These thoughts are excellent. So again, the question is, why do you think people are under suspicion, even if they've been in demonstrated long-term recovery where they have repaired relationships or re-engaged with the community, working? Ooh, this is a profound statement. People perceive people who use substances as manipulators. And some people think people will go back to using substances. Absolutely. So even if somebody has had victory and healing over substance use disorder, they still have to deal with this stigma and discrimination, even after years of demonstrating that they've put their heart and soul into their recovery process, whatever that process is. And that's a very nice comment too. People are afraid of what they don't understand. Absolutely. And that's why getting more general public education out there about this disorder, I think can really, and we'll talk about some of those tips at the end of this presentation, can really make a big difference. So I'm sure all of you, I do not claim to be a brain expert or a scientist, but I have done a lot of research and taken training myself and talked with a lot of people about the science of substance use disorder and recovery. And some of you may have even more information, and so if you want to add some points, please do. Just want to look at a few more of the people's thoughts in the chat box. So under the suspicion question, it can be from the self to forgive themselves, and from their environment, others would continue to remind them of what they were, right? So bringing past history back. So substance use disorder, the new definitions, the American Society of Addiction Medicine characterizes addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. And the National Institute on Drug Abuse defines addiction as a chronic relapsing brain disease that changes the structure and functionality of the brain. So why do so many people still think of substance use disorder as a moral failing and still refer to individuals with substance use disorder as meth freaks, alcoholics, junkies, crackheads, garden variety drunks? These are all very derogatory terms. So substance use disorder is compulsive non-medical use of a substance, loss of control over its use, and then continued use despite negative consequences. So let's think about, why do people start in the first place? And there's really 4 basic reasons, or maybe others too. But some is to feel good. So if any of you are people that might like a glass of wine, think back to, why did you even decide to have that very first glass of wine in your life? So it's for opioid use disorder, that takes away all pain, emotional pain, physical pain. So if somebody doesn't feel good, they may use substances to feel better. to do better, and often we don't talk about this, but elite athletes that end up using different substances to be better at their sport, even if it's illegal, that would be an example to do better. Or maybe a student is under incredible amount of pressure to get all their work done, and so they take a substance so they can stay up all night and study. And then curiosity is often what happens with our youth and young adults. Between peer pressure or thinking that other people are having a lot of fun, they may initially decide to start using substances. And of course, this is extremely dangerous because their brains aren't fully developed. Often people may suffer from social anxiety or stress or depression and find out that a substance eases that. Maybe they take something and they feel less anxious. So stress can play a major role in starting and continuing drug use, also as well as relapse. And some of the drugs, they're so powerful now that they can induce intense feelings of pressure. And this initial euphoria is followed by other effects, depending on the substance that they're using. So, Leanne, could we do the second poll question?
Yes, we sure can. I'll go ahead and get started. And the question is, do you think that substance use is a choice? And you should see that now as a poll. And we'll give everyone another minute. And again, the question is, do you think that substance use is a choice? We're at 50% response rate, and we'll give it just a few more seconds. Okay, I will go ahead and close the poll. And it'll be a few seconds for that to finish. Hannah, I'm posting the poll results now, so you should be able to see them.
Thank you. So 35% of the people that responded believe it is a choice, and 17% out of those that responded said they don't believe it's a choice. And thank you for your participation in that poll. So initial decision to take a substance can be voluntary. And after time, substance use takes over and self-control becomes impaired due to the structure in the brain change. physical changes in the areas of the brain that are critical to judgment, decision-making, learning, memory, and impulse control. An example of an involuntary beginning of substance use disorder would be someone given painkillers after a surgery, powerful painkillers that, and maybe they were overprescribed, so that during the time the person is taking them for a medical condition, they can, during that time period, become addicted to that painkiller. So they never started because they were feeling socially anxious or had a really, had trauma in their childhood, or they were curious. They were taking a substance for a medical condition, and during that period of time, their body became dependent on that substance. The medications and the street drugs are so powerful today, they're taking over much faster. Some of the designer drugs, which I find that even an interesting term, why we would call any drug a designer drug, because that makes it seem appealing. Some of these are so dangerous that somebody can be completely addicted after the first use. And the physical changes in the brain identified on this particular slide are all areas that are needed to make logical choices. So if their brain structure has changed and they may not understand that at all, a lot of people, most people don't understand why they continue to use substances and why they can't stop. So I will weave a little bit of my story in now. So I started using substances at 13 years old. I always felt extremely socially awkward, sort of out of the loop. I guess another example would be I felt like I was on the outside looking in, and I didn't understand how people could feel comfortable in social situations, which I guess would be termed as social anxiety now. And this is a long time ago. You guys can do the math. So there wasn't this kind of information. There was not very many places to reach out to. And I didn't understand why I had gone along this path. I certainly knew it wasn't a good path to be on, but then I would find myself getting deeper and deeper into this. And I it's a common story of starting with just trying a little bit of alcohol, and then it just snowballed into becoming an IV drug user. Human beings, our nature, our natural desires to survive. So the brain structure changes can really take away that human desire to survive, and people struggling with this disorder are, slowly but surely taking away everything in their life that is meaningful to them. And it's very difficult for family and friends to understand. And so I can see, without having this information, without all of you getting this information out there and talking about this in the media, why people do feel the way that they do. So substance use disorder goes beyond tolerance. And so tolerance is reduced drug effect with repeated administration of the same dose of a drug, or need for an increased dose to maintain the same level of effect. And it's not just physical dependence. So being able to take more and more drugs or drink more and more alcohol is tolerance, but this goes above and beyond it. For example, say someone has a back injury and they're taking pain medications, and they notice that their body adapts to the medication that they are on, the dose. After a while, they don't feel enough relief from pain. When that happens, they may go talk to their physician about it. They don't go from one doctor to another to find more pain medication. So I'm sure most of you know how this works, but dopamine is a neurotransmitter present in these regions of the brain that regulate our movement, our emotion, cognitive ability, motivation, and pleasure. So, for example, if you are an exercise person and you go and run 5 miles, you will create more dopamine in your brain, and that's why people feel so good after they work out, because it's a natural creation of more dopamine. And this is why people are more motivated to exercise once they have started an exercise program. They always feel better after they move. They may feel happier, think clearer, and they're motivated to repeat the process and feel this pressure and also relief of stress. So substances create high-level dopamine rushes, much higher than going for a run or eating a yummy piece of chocolate cake. So just I want to ask a quick question. What happens to people's emotions if they've had too much to drink? So some comments here. Alcohol can do the same thing when used as a coping mechanism for stress. Every time with the increase of stress, the amount of alcohol use also increases. So yes, it's a very vicious circle. Lose inhibitions, absolutely, and which can create shame later. So if they lose inhibitions at say a company party and do something that they're ashamed of, that can affect their emotions. How about movement? Next question is, what happens to people that drink too much as far as movement goes? Or cognitive ability? Yes, uncoordinated. They may stagger because their brain is being affected, and they may not even realize. They may start slurring their words. Cognitive ability goes down. And motivation. So some substances really decrease motivation. Some people that may smoke a lot of marijuana may not feel very motivated to make changes or just motivated at all. So with this rush of dopamine, this overstimulation of the system, which rewards our natural behaviors, produces this euphoric effect sought by people who use drugs and teaches them to repeat that behavior. Going back to that example of exercise, people are more and more motivated to exercise if they're involved in an exercise program. And unfortunately, the same thing happens. People are more and more motivated to use more and more substances because of this reward. And natural rewards like eating and exercise don't come close to the amount of euphoria they feel with a substance. So whenever this reward circuit is activated, the brain knows that something important is happening and it needs to be remembered. It teaches people to do it again and again without even thinking about it. And often, even years in recovery, somebody may smell a smell or drive by a place that they used to use substances in, and the brain remembers that, and that can be a reason why somebody may find themselves in symptom recurrence, relapse. It's a powerful message that the brain gets. So drugs release from 2 to 10 times the amount of dopamine, and if they're used, smoked or injected, they get that increase right away. The effects last much longer. And this is such a powerful reward that it motivates people to continue. Brain learns to do this very well. So when you think about it, if somebody is using substances and they're getting this dopamine rush and then they stop, it takes a long time for people to start feeling natural to experience any pleasure because it's been drastically reduced. And so you will often hear people, especially in their first years of recovery, they have a hard time with joy. They may feel very flat, emotionally flat or numb. And that is also a reason somebody may start using substances again, because they feel like life without them, there's no pleasure at all. So it takes time for the brain to balance that dopamine level again. We're just going to do a few more slides and then take a break. So tolerance, as you all know, is a person who's been using substances over will now need to use more in order to get that same dopamine high. And that with opioid use disorder, people are taking huge risks. And of course, we all know we're losing, I believe the new statistics are somebody every 18 minutes in the United States with an overdose. And so drug withdrawal is the group of symptoms that occur upon their abrupt discontinuation or decrease in intake of medications or recreational drugs. And so for opioid use disorder, that withdrawal is so intensely painful because it affects not just the brain, but so many different places in the body that people that may even have every intention to stop using a substance experience that kind of pain, and they can't handle the pain, so they will start again. And some alcohol, an abrupt stop in alcohol for somebody that is using an incredible amount can be deadly. And so what I just mentioned earlier and 2 slides ago is long-term substance use can trigger adaptations in habit or non-conscious memory systems. So these environmental cues can just trigger these uncontrollable cravings, and the individual may not even understand how they ended up starting to use substances again. And so the behavioral effects, intense impulses, cognitive impairment, memory, eroding self-control, and less capacity to make sound decisions. And these are all the results of the brain structure changes. So it's not only the general public, but people using substances, understanding about the brain structure and the changes will help them to understand what's happening and may reduce some of the shame. So Leanne, I think this would be right at the top of the hour, a good time because everybody's been very respectful and engaged and writing in chat. Thank you, to just take a 5-minute break.
Great. Thank you, Hannah. I appreciate that. So everyone, we will go ahead and take our break and come back promptly at 11:05. Welcome back, everyone. It's 11:05, and Hannah, if you're ready, we can go ahead and resume.
Thank you, Leanne. I wanted to stop here before we move into the next section and see if anybody had any questions.
Hannah, we can give it a few seconds.
Okay, well, if there's no questions, we'll move on. But if you have one throughout, we will have a little time at the end to address any questions that you have. So we've come a long way in science, and scientists use different research methods. So PET scans, SPECT imaging, and MRIs are used as tools to study the brain. So PET scans use a special dye containing radioactive tracers. Certain organs absorb these tracers, and this helps doctors to identify how well organs and tissues are working at a cellular level. MRI scans can't do this. Glucose is the main energy source for the brain, and this test allows doctors to see less active areas of the brain due to substance use. The reduction in activity results in disruption of many brain functions. MRIs use a large magnet, radio waves, and a computer to create a detailed cross-section image of internal organs and structure. There's no dye used for this test. And SPECT imaging is nuclear imaging technique using gamma rays, which are electromagnetic radiation at high frequencies that are stronger than X-rays that capture cerebral blood flow, and this information is in three-dimensional imaging. So I'm going to show you in the next few slides some actual images of individuals' brains and what substance use does to the level of activity. So this is a comparison of someone who does not use substances and somebody that is addicted to cocaine. And as you can see, the level of activity in the normal subject is all in the yellow and the red, and you can see the decreased activity in the brain in the person using cocaine. It's profound. And here's a comparison of somebody that's a moderate drinker compared to somebody, this is their language, alcoholic, but somebody who is struggling with alcohol. And you can see the large holes in the brain image here. And so again, this isn't somebody that using cocaine. Comparison subject, the red and the yellow, a very active brain, and then even 1 month after cocaine, the dopamine receptor may contribute to the loss of control in cocaine users, and you can see the difference in the activity and how quickly it can happen. So SPECT imaging, you can see this three-dimensional image, and you can see the reduced brain blood flow in the person that is addicted to heroin. So some additional findings from the chronic drug use alters the brain's anatomy and chemistry. These changes can last for months or even years after the individual has stopped using the substance and they are in recovery. And that's an important point. It's called post-acute withdrawal. So often we think about withdrawal, the initial acute withdrawal when people are in treatment, and and all the physical symptoms can be extremely painful. What a lot of people don't know about is this post-acute withdrawal syndrome, where the brain is healing, and some examples of that would be memory. So say someone's in early recovery and they start a new job, they may not be able to hold new information for very long, which can be frustrating for maybe the employer if they've just instructed them on how to do a certain task, and in a very short time the person doesn't remember. It can affect sleep. So people often report that their sleep is very disturbed. That can even last for a lifetime. So it does take, the brain can heal and does heal if people stop, but it can, even all these things I'm describing in post-acute withdrawal can make it very hard for somebody to stay in recovery. And then, of course, additional factors can be the substance itself, how long somebody has been using it, their route of administration, their motivations for use, and frequency and length of use. So in layman's terms, because again, I'm not a doctor or a scientist, the part of the brain that becomes changed, two very key parts. One is the limbic system, and within that is the amygdala, which is our fight, flight, or freeze response, actually becomes larger. And then our prefrontal cortex, which is our logical reasoning, where we learn, where we make decisions, where we do future planning, actually gets smaller. And then factual memory storage, the hippocampus, is also decreased. So people have a hard time with remembering things. So if their fight, flight, and freeze part of their brain is larger, and then their logical executive functioning smaller, they may not understand why they overreact, or they continue to use substances, and they may not be thinking about future planning and struggle with learning new things. And so this takes time to heal. The good news is that the brain does heal. And this is so important. This technology and the science, it enables scientists and us to see the brain can heal. And this is also a powerful message that we want more and more people to know about it. It's so important because the reason up until now, historically, it was based on lack of willpower, lack of caring about anybody else, being selfish, self-centered. And with this new technology, with this new science, can really help combat the tremendous amount of stigma and judgment and myths and misunderstandings. So here's an example of recovery. So methamphetamine, which was the substance that I used, you can see the normal control on your left. 1 month after detox, you can see activity starting to come back. And then 14 months after detox and in recovery, you can see that the brain is very close to the normal control. And this is the good news. Here's another example of normal brain activity on your left, and then just a very short amount of time abstinent from cocaine, and then 100 days later, you can see the activity starting to come back. And if you remember a few slides back about the heroin user, There's the normal on the left, the active heroin user, and then 1 year free, drug-free of that substance. You can see the brain is starting to look more and more like the normal comparison. So why are we still shaming individuals with a medical condition? So over 20 million people are in recovery in the United States. Today, people are making substantial progress from active substance use disorder through treatment, recovery. Success rates can be compared with that of other chronic relapsing conditions such as asthma, diabetes, and hypertension. So often the media is talking about the epidemic being out of control, and not that I disagree with that, but there's not a lot of media or talk about a tremendous amount of people that are in recovery. And that needs to be an equal message when we try to reduce stigma. So in this section, I would really love some active engagement when we talk about language. Words do matter, and changing the way we speak about substance use disorder is extremely important because language is so powerful. I've always loved this quote: words are so important. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed. So there's a dandelion that we all mow down with our lawnmowers because it's a weed. But whoever decided that initially, that could have been a very unique flower that people actually wanted to plant in their gardens or in their lawn. So it's really about what labels do to people. Labels turn people into things. So language does many things. It elicits deep feelings. So if somebody, it could either be very positive or very negative. So somebody might say, you're a, incredible organizer, and that might make you feel very good. Or somebody might have said something to you at one point in your life that you can even remember when, who, and even what you were wearing because the word cuts so deep, and that's the negative side. Words carry action. They define the nature of our relationships. So whatever we say either raises people up, keeps things neutral, or tears people down. And importantly, it calls up a host of imagery. Language also persuades others to see things from a different viewpoint. So the host of imagery is what we see in all our media, and it just adds so much into the stigma that we carry. So here are some examples. Here's some imagery of drug addicts and alcoholics, right? And so if you hear the term, even if you're very familiar with all this, you know this is a disorder, when you think of when somebody uses the term drug addict, is this the type of imagery that comes to your mind? Oh, and I love this comment in the chat. Language is the way we know who we are. So if we label the addict a junkie or an abuser, it leaves no separation between an individual and this disorder. Even the word disease can complicate things because it can reinforce addiction and stigma. It can be the word disease itself. While the word disease in general states that a part of an organism's body is impaired, it has narrow but long-ranging consequences for somebody called a drug addict. So these are not very flattering pictures, and that's often what people think when they hear drug addict is dirty, homeless, distorted facial figment, lazy, criminal. And so we really want to think about the language that we use. So here's some of my friends, people in long-term recovery. This was at our 2018 America Honors Recovery event. People receiving awards for the amount of work that they've done over the years to help reduce stigma and help more people find recovery. You can see they're all smiling and happy, and these kind of images, I think, need to be in our media to show people that recovery is real, and people are people. They're not a disease. And here's some more famous folks that have been in long-term recovery. So I'm going to ask the group, what are some words or phrases you've heard that perpetuate stigma around substance use disorder? If you wouldn't mind putting some of those words or phrases in the chat box, I'd like to take a look at them before we move into doing some language replacement. So what are some words or phrases you've heard that perpetuate stigma around substance use disorder?
And I would encourage everyone, as you respond, remember to respond in the chat panel to both the presenter and to the host. That way Hannah can see your responses too.
Crackhead, junkie, useless, wow. Loser, relapse is inevitable, waste case, they'll never change. So you can see how, thank you all for doing this, worthless, sorry for writing this. So if these are all things that I felt about myself as a loser, worthless, useless, and that's where that self-stigma I talked about earlier in the presentation is so dangerous, because this is what people are saying, and you start believing that, you get to the place of why bother even trying to stop. Somebody wrote, I always hated fall down drunk. Oh, and somebody mentioned that their brother was in recovery has been in recovery for 30 years. Some other words, hopeless, cursed, damned, demonized. Yeah. Just a little bit of fact, the term dry drunk actually comes from, when I mentioned post-acute withdrawal syndrome, one of the most severe symptoms of it, not as common as the others, is a lack of coordination, and that can happen for a long period of time. And so that's where that word dry drunk came from, but it's now a term that's used within a 12-step community as somebody that's not involved in a recovery program. So words can really hurt. Thank you for your engagement in that question. So reasons for changing the language, there's so many of them, but helping individuals not feel like a loser or bum or worthless or useless. They're a beautiful human being that has a disorder that could be lifelong, deadly. It helps people, if we change language, we're treating people with dignity and respect. Maybe more people would come and seek help or ask for help if they didn't have these words and the shame that comes with them. Right, absolutely. First person language. The mental health community did a great job, and the recovery community is following that with turning things around to people first language, because we are people first, and then whatever we have for a condition is not who we are. It's not our whole selves. Might allow lawmakers to appropriate more funding and help the public to understand that this is a medical condition as real as any other. So changing the stigma will benefit everyone. It will allow patients to more easily regain their self-esteem, allow lawmakers to appropriate the funding, allow doctors to treat without disapproval of their peers, allow insurers to cover treatment, helping the public to understand. Choosing words to use more carefully is one way we can make all the difference and help decrease the stigma. So just a brief history on our language. Many derogatory terms were championed during the war on drugs era. Is an effort to dissuade people from misusing substances, but as we all know, that didn't work. Education took a backseat. Little was known about the science of addiction, and the language should be changed to reflect today's greater understanding of the science of substance use disorder and the impact on the brain. Great resource if you're looking to work with your agency or organization or just for yourself is the Recovery Research Institute. Dr. John Kelly and his team did an incredible amount of research and work around language and stigma. And on their website, they had developed the dictionary where they took every possible word that could possibly what they call be a stigma alert. So it could have more than one meaning. And then within that same research, they came up with some replacement terms as a huge national effort to change the language around substance use disorder. So if that's something that you're interested, it's available on that website. Excellent resource. So people with eating-related conditions are never referred to as food abusers. They have an eating disorder. So why are people with substance-related conditions referred to as substance abusers and not having a substance use disorder? And that's a direct quote from him. And like I mentioned before, the mental health community has done a lot of work around this. And so they've moved from marginalizing language to replacement language. Words like non-compliant means the person is not in agreement with the treatment plan. They're choosing not to go with that treatment plan. They could choose something else because people deserve to have a choice. Low functioning is one of my least favorites. If they refuse or decline, they've said no, and it goes on and on. So this is the mental health community has done an incredible amount of work, and we're grateful for that. So I'm going to do a little language practice here, and all answers are good answers. But when you hear the term clean and sober, which is commonly used, how does this phrase potentially increase stigma? What does it imply, and who does it eliminate? What are your thoughts on that? So if you're not sober, you're dirty, right? So the opposite of clean is dirty. So again, these are great answers. Thank you for participating. With the imagery that we see and then words that we use perpetuate stigma. Who does it eliminate? When you're using that phrase, clean and sober, who does it eliminate? I like that answer, the person, right? Clean and sober is actually a term used in a 12-step program. I love your answers here. I wish I could be there with all of you. So like you said, the word clean raises the image of a dirty addict, implies that one was once dirty and unacceptable. The word sober does not imply joy or happiness that one experiences in recovery. And it is specific to 12-step recovery, so it eliminates other pathways of recovery. So replacement term idea in recovery from substance use disorder. Oh, somebody just said exactly what I just said. All the other folks that don't choose to participate in 12-step programs. So my next practice round, I love your answers here. Drug habit. So again, how does this phrase potentially increase stigma? What does it imply, and who does it eliminate? And please keep engaging because I really like seeing your thoughts. So how could drug habit perpetuate stigma potentially? Absolutely. Habitual, then it's very frequent, imply. Remember, a drug habit is also eliminating the whole piece around the science of recovery. Thank you so much for putting these in the chat. A habit isn't an illness. Exactly. It's a behavior. So we're going backwards in thoughts using this term. As the one behavior. So calling substance use disorder a habit denies the medical nature of the condition and implies that resolution of the problem is simply a matter of willpower and in being able to stop the habitual behavior. So the replacement term substance use disorder is very recent. If you think about it, we've been talking about this as drug addiction or drug abuse for years. Another comment about habit from you all makes me think of 30 days to break a habit. So it minimizes the severity of substance abuse disorders. That's an excellent comment there. So there is progress. Individuals and organizations are adopting the new language nationally, and we see that because we are from a national advocacy organization. Habits, you guys are putting so many comments in, this is excellent. So we are torn between the new language and 12-step and a big book. I'm really glad that you put that in the chat because I believe that within a 12-step community, if you're that was my original recovery path. It's not now, but then people in recovery in the program saved my life. They were the first people to embrace me and make me feel less ashamed. And I think within a 12-step community, when somebody says, "Hi, my name's Hannah, and I'm a drug addict," it's embraced. It's people are like, "Yes, and we're glad you're here." But outside of that community, it's a completely different perception that can happen. And it is a real pull. So thank you for bringing that up. So organizations are changing their names to remove marginalizing language. So often abuse is in an organization's name, and we've seen a trend of people replacing that word abuse and changing their organization name. And even some marginalizing language has been removed from the DSM-5. So we are definitely making progress and would like to continue that. And so some of the things that were removed from the DSM-5 was recurrent legal problems, dependence, and abuse. So that's exciting and it's hopeful, and I hope you all can go out there and join the national recovery language movement. So here's some tips For if you're a leader of an organization or not, maybe you can bring this to your organization or community. So the first tip is perform an organizational language audit of existing materials for language that may be stigmatizing, then replace it with more inclusive language. So that would be any of on your website, any flyers or signs in your organization. So it's a good thing to explore in your policies and procedures what language you're using, and then get together with your team and come up with words that may be more inclusive. And then critically reflect on the type of information you choose to disseminate. So I worked for an organization, and part of what our organization offered for a service was all kinds of free materials around substance use disorder. And one day we were looking at all this material, and there were those same images on these flyers about different substances that we saw earlier in the presentation, the less than flattering images. And so we took them all off the shelf. That's not the message that we wanted to project. So, and also think about the source of your message. Is it reputable? Do you trust the source? And is the message grounded in research? And is it evidence-based? So it's something to think about if you do disseminate any information around substance use disorder. And anytime you develop a message, whether it's around substance use, prevention, or recovery, consider it as an excellent opportunity to dispel myths and convey respect. So thinking about your message, who is my intended audience, and how can I use language to reduce stigma when communicating with the group? And am I correcting negative attitudes held by potential allies? So it's a very intentional thinking about how we're talking about this disorder. And then internally, focus on the inadvertent ways that staff may be perpetuating stigma in day-to-day conversation. And that can also be like within your community, your social circle. Ask them to think about perceptions they hold of people with substance use disorder and the words and language they use in discussing individuals or cases, which is one of my least favorite words. People are not cases. And how can they explore alternative language, and how could your organization adopt new language? And again, using John Kelly's work with a dictionary, that might be something to use with a team to explore new ways to not only say things, but the images and also the written word. So what now? Somebody mentioned earlier in chat, education. It's so important to get the new science, the new language out to as many people as you possibly can. And also putting emphasis on recovery and talking about that it can and does happen, and people can be in recovery for the rest of their lives. And they're productive, beautiful human beings as part of our communities. Oh, I like this tip idea. I was thinking we could have a swear jar, something like a swear jar, where the workers would put in a quarter every time they forget to use recovery words. That is an excellent idea. I love that. Very creative. Personal witness, putting a face and voice on recovery, meaning having more people in recovery speaking out so that people can see that they're people and that recovery does happen. And I think that we've made huge progress because people are actually daring to step forward and say, I'm a person in long-term recovery, and they can talk about their story, but also more about their recovery. We've come a long way from hiding in church basements. It's taken a lot of work by some pioneers, but when somebody tells their story, often people are moved and may look at people differently. And like we were just talking about, changing the language and terminology. So stigma doesn't just affect the person with substance use disorder. It affects their families, their friends, their employers, healthcare providers, and society as a whole. So it's not just the individuals that have substance use disorder or are in recovery, it's everyone. I'm going to give you an example of discrimination in my story. I was, again, very young, and I quickly recognized my freshman year in high school that I had a very serious problem already. And so I decided to go to my guidance counselor on my own and ask for some help. And I was drinking that day in school, and I knew I just had that moment of, I am going down a path that I don't want to go down. I was really scared. Excuse me. And I went to the guidance counselor, and I actually got suspended from school for a few weeks because I had been drinking. And that was the beginning of a trajectory downward, because I was punished for asking for help. My family didn't understand. They were angry. And, if you've heard other people's stories, it was the beginning of shame, and that I am like bad to the core. And so it led to serious self-destruction. And it's a miracle that I'm here today. And that's why I do the work that I do. So some individual simple things besides changing language is just offering compassionate support, kindness, listen while withholding judgment. So even if, have multiple worldviews at the same time, as listen and maybe just put the judgment aside a little bit so you can really hear the pain these people are in and the shame that they're trying to work through, and see them for who they are, not what substances that they use. Because when I was a little girl, I was not planning on ruining my family. I wasn't planning on being a teenage runaway. I wasn't planning on being a high school dropout. I was planning on being, what little boys wanted to be, whether it's a doctor or a scientist or astronaut. So this is not my plan as a young person, and again, so grateful that I don't have to live that way anymore. But that's just an example of see the person for who they are. They were not born planning on being so self-destructive. Again, simple steps to make change: avoid hurtful labels. Remember, you don't know the backstory. We never know what somebody had. We might have had similar experiences, but we don't know what somebody's been through, why they may have even started using substances, what the rest of their life looks like. So we have to remember that we don't know the backstory, and that's where we want to listen. Just treating people with dignity and respect might save their lives. And speak up, like have the courage to speak up if someone is being discriminatory or treating someone with substance use disorder with disrespect. So, if somebody's crossing the line of common decency, as change agents, you can speak up and hopefully change that thought process. And then somebody mentioned in chat, continue to show the relationship of substance use disorder and other diseases which are in the same way behavioral, related, or hereditary, and how they may progress and become chronic: diabetes, hypertension, cancer. Exactly. So comparing it to some things that people might be able to get a better understanding. So knowing the facts about substance disorder, also knowing how to talk about it, just like this example that was put in chat, knowing your local resources in case somebody comes to you personally for help, tell others of the facts anytime that that opportunity comes up, tell others of the science, and try to replace negative attitudes with evidence-based facts. And I daily have opportunities. It could be on the elevator, in an Uber ride, in a store where somebody might be saying something that's derogatory that I can step forward and talk to them about. So on a community level, you can participate in an annual Recovery Month event. They're held all over, and they're energizing, inspiring, and there's people that are happy and living great lives coming together to send that message that it's possible. And if you've never been to a recovery event, they're an inspiring gatherings, and so I strongly encourage you to go to one if you never have been. Let the media know when they're being stigmatizing. So I live in Vermont, and we have a local TV channel that I enjoy because they actually talk about some positive things on the news too. It's a nice balance. But there's one reporter who seems to be assigned to anything to do with substance use disorder and uses all the language that perpetuates stigma. So I actually wrote a letter asking if the language could change, because it's a local channel that Vermonters are watching, and so that's a place that you could also reach out to. And then invite individuals in recovery to all the tables. If you're doing work around substance use disorder, those people need to be at that table to help with whatever work you're doing. And I see somebody talking about they had a huge event on September 22nd. That's great. So I just want to say again, thank you so much for all your engagement today. And just some final words: that 1 in every 3 households is affected by substance use disorder. So if you were to stand between 2 people and you were to look to your right or to your left, one of you, either if it's a family member or a friend, a colleague, or yourself, you've been affected. Regardless of whether you or your loved one is experiencing substance use disorder, it's on everyone, all of us, to offer support and encouragement for those who are affected by this medical condition. And we can help spread the word of recovery to show people that it works, there's a solution, and that we don't have to live that way again. So I just wanted to take this opportunity to ask if there's any other questions or comments, because I know we're almost ready to close, and I, again, am honored to be here with you today.
And Hannah, while we wait for any additional questions, we did have one that was raised earlier in the presentation. It was around the section of the presentation where you were showing the brain imagery and talking about changes in the brain. And the question that came in is, does the brain heal completely?
Well, that's a great question. Again, I'm not a scientist or doctor. I think that it can vary a little bit. So, for example, I started using substances before the age of 15, and there can be some additional long-term damage if you're impairing or changing the function of your brain before it's fully formed. So it was a long recovery process for me around some things. And also length of use. I think they're all, it's not sort of a one size fits all, but what I can say is that brain can recover quite a bit. And that would be a good question to ask somebody like Dr. John Kelly or other people that have done extensive research.
Thank you, Hannah. And I think that you have also included in the presentation some great references that we will make available when we share this presentation in about 5 days. People will be able to tap into some of those references that you've included in your presentation.
Great. And thank you.
We have certainly received a lot of positive feedback today, and our attendees have clearly, appreciated, you sharing your experience and expertise with us, and I appreciate that as well. I'm just checking to see if we have any final questions.
I think there was one comment in the about long-term alcohol use, like how many years before the brain can't heal. That is one substance that if it's, heavy drinking for a long period of time, that can affect the brain permanently. It doesn't mean that there can't be some healing, but that's it's a good question, but I couldn't tell you exact amount of years. Again, it would vary on every, all parts.
Thank you, Hannah, for picking up that comment. I appreciate that. And if you are ready, Hannah, I'm going to go ahead and take control back of the presentation.
Absolutely. Thank you, Leanne. Thank you, everyone, for your nice words, too.
Thank you. And I'll go ahead and provide some concluding remarks and information for the group. Do remember that when I conclude today's webinar, your browser is going to take you to an evaluation on our website. If you want to receive continuing education credits or a statement of credit for today's webinar, please do complete the evaluation for us. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For continuing education to be reported to CE Broker, for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number at least the first time that you register with our community. After you register or sign in, you'll be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FATA system. And this helps us connect your attendance with your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. That should hit your inbox. The sender will be FATA On Demand Messenger at WebEx. And do remember that the evaluation will close at midnight on Thursday, October 11th. And also, we do not email your statements of credit to you. Instead, after we verify your attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Then finally, in closing, of course, we do want to thank Hannah again for sharing her experiences and expertise with us today. We appreciate that very much. And I'd also like to thank you for participating in today's webinar. And for those of you who are in the path of Hurricane Michael, we do wish everyone to be safe over the next couple of days and to take care. And of course, in closing, we also would like to recognize and thank especially the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, for funding today's education. So have a great rest of your day. Do try to stay safe, and hold now for the evaluation. Thank you so much.